Hi, everybody. Thank you so much for joining me today as we start talking a little bit about the cardiac section of our protocol. What you're seeing on the screen right now is just our Delaware County pre-hospital clean copy, and I'm just going to show you the cardiac, but I'm not making any PowerPoints today. All I'm going to do is actually just take you through what we're doing here and kind of just show you what our protocol is and kind of walk you through it. My plan here is actually to go through more in order rather than in alphabetical order. Because if we did alphabetical order, we'd be starting at bradycardia right now. It's kind of weird just to take off from there. And so we're going to start with chest pain and go from there. So in our chest pain protocol, what you see here, and I'm going to be using some of the tools here, is boom. We can see our clear patient goals that are no big surprise. Identify that STEMI quickly, get that 12 lead within 10 minutes, determine the time of onset of symptoms, and progress from there. Of course, some of our big goals are definitely treating people such that we can make sure that they're ready for the best possible care they can have inpatient. And one of those things is administering aspirin and transporting to an appropriate facility. As we go down through the protocol, we can see that we're talking about titrating our oxygen to appropriate sats of 95%. Keep in mind, there's been data out there which have been talking about keeping people at 100%, which may have poor outcomes. These studies themselves are retrospective, and so they're not giving us the best guidance about how to do this, but it is something that we can kind of lean on. And so titrating and making sure we're over 95% is probably most appropriate and the most data supported. From there, really doing our cardiac monitor, doing our 12 lead EKG, repeating every 10 minutes as needed based on the patient's changes, and of course transmitting this so other people can share in the joy of it all. Obviously, making sure we give some aspirin. Moving over to actually IV fluids as needed. Here you can see we're focusing on hypotension. You're going to see that systolic blood pressure of less than 90 millimeters of mercury of being a pretty consistent marker for hypotension throughout the protocol. And then we're into some pain management. Of course, we focus a lot on nitroglycerin as a strong pain management piece. It has significant benefit, and there's good physiology that supports its role in ACS. However, it does not improve outcomes. So something to think about. Other options, of course, with anxiety and of even pain management are appropriate as we go to treat these patients. But when all is said and done, if it's STEMI, notify the hospital, go to a primary PCI place where you could actually get the work done. And of course, we're going to try to hit those mission lifeline benchmarks, right? We want a good door to balloon time of less than 90 minutes if we can. So that is our basic STEMI protocol. And I want to take you now to another area. We're going to talk about near syncope or syncope. So these are kind of the backbone of our cardiac area that we see a lot of patients in. So starting with the near syncope, again, so we're going to stabilize, resuscitate these patients as needed, initiate monitoring as needed, and of course, transfer for further evaluation for a lot of these high-risk patients. And a lot of them are truly high risk. We should be thinking about abnormalities that we discover in our physical exam and really thinking about the different issues that could cause syncope versus near syncope. Everything from cardiac dysrhythmias, ischemia, infarction, hemorrhage, shock, GI bleed, sepsis, all those things are on our list. And this is why syncope and near syncope becomes really challenging. As in the rest of our protocol, we're going to keep coming back to this adult universal protocol, adult universal care. And we used that last time, and we were able to talk a little bit about adult universal care last time that we were together on our Zoom meeting. Of course, you want to obtain that detailed history. You want to start looking at airway management as needed. And of course, you can click this hyperlink. It'll take you where you need to be for further information on that. Give oxygen as appropriate. And really, if we're thinking hemorrhage and we're thinking lots of shock, let's think about trauma management too. If the syncope or near syncope is due to trauma, that's something really important for us to think about. Obviously, give them IV fluids and get that 12 lead monitor and keep them on monitor so we know what's going on as we're transporting. Now, one of the big things is, like I said a minute ago, there's a lot of etiologies for people to have syncope and near syncope, and one of those can be arrhythmogenic events. And of course we have fast and slow arrhythmogenic events. So let's review those protocols as we're going through. So let's start off with the bradycardia. So please excuse the quick scan through. And here we are at the bradycardia protocol. In the bradycardia protocol, of course, the biggest thing here is to maintain perfusion. We want to treat the underlying cause, and there's multiple things which cause the underlying issue of hypoxia, shock, and so on and so forth. And that's what we really want to look after. Again, as we had with our other protocols, we have adult universal care to start us off. Airway management, again, these are all nicely hyperlinked. Administer oxygen as needed, and then go right into our cardiac monitor in our 12 lead. In this 12 lead, we're probably going to see that bradycardia. And it's going to give us some guidance to start thinking about what is causing this bradycardia. Definitely check a finger stick glucose, see if there's an issue there that may be setting us up for bradycardia. So it's kind of a vicious cycle, right? So some of the situations could be like hyperkalemia, which is because of severe hyperglycemia from a diabetic who is causing them to be hyperkalemic, which is causing them to be bradycardic. So this glucose number is one of those ties there. As we continue on, you have IO for our fluids, and now we have to make a decision. Are they hypotensive or not? And again, that 90 millimeters of mercury that I mentioned before has come cropping up again. So let's assume that they are hypotensive and they need assistance with perfusion. And in this situation, we're going to treat them with atropine. And notice the 1 mg IV or IO. Again, this is for being consistent with the AHA guidelines. And also consider calcium gluconate for these patients, particularly if they are end-stage renal or dialysis patients. Calcium gluconate is a great inotrope, and again, it can do that job. But if the bradycardia is due to hyperkalemia, this will actually get you going in the right direction. Consider, of course, pain management, because if this is a situation where you're going to need to start doing some pacing and things like that, well, you're all set up with a little bit of pain management on board already. So the real question that a lot of people ask is, when we come to the point of making a decision for management of bradycardia, do I go pressors or do I go pacing? And there's no good data telling us which way to go. Both are equally appropriate. Now, in our protocol, what we have first is external pacing with the Zoll on the left here. And you can see, consider sedation for these people. I would highly recommend sedation if you can. Obviously, some situations are so emergent that you can't get some sedation on, but if you can, that'd be a great thing. And you have a number of options here. On the other side, you have push dose pressors. And so this is our new push dose pressor protocol. We're going to be talking a lot more about this, and I'll be doing a Zoom a little bit on this to give you further information on this. But in this case, your push dose pressor after you make it up is 10 mg per ml, per ml. And at that point, you're going to give 1 milliliter of an IV push every 2 minutes for appropriate pressures. Now that's our patient that is hypotensive and we need to amplify perfusion. For the patient who is normotensive or greater than our 90 millimeters of mercury, in this group, we're going to give a little bit of fluids and be prepared and put those pads on to prepare for the situation. And you can still consider giving a low calcium gluconate to these patients. So this is our bradycardia side of things. What about our tachycardia side of things? So we're going to skip down to tachycardia, and I'm actually going to start with our narrow complex, and then we'll go into wide complex. And so with our narrow complex tachycardias, so we want to maintain perfusion. That is the focus of so much. And we want to restore that sinus rhythm if we can, because that is a key piece to stabilizing. Now, the underlying cause is often challenging for us to manage, but it can be anything from medications, drugs, history of dysrhythmia, CHF, like with our AFibers. And so it all kind of ties together there. Again, it starts with our adult universal care at the top. We have airway management occurring. We have cardiac monitoring, getting that 12 lead EKG, because it's going to tell us what's really going on here. We're going to place that IVIO. And now again, we're at a branch point. Are we stable or are we unstable? Now, I'm going to start with our unstable, because for me, if it's unstable, I mean, we cut the chase a little bit, but I do want to direct you at this box of stable versus unstable. Notice the numbers here: systolic blood pressure less than 90, shortness of breath, altered mental status, chest pain. So we're giving you a clear direction about who is and how is it defined to be unstable. And now if they satisfy that unstable criteria, here you go: synchronized cardioversion, synchronized cardioversion. Of course, sedation is important. Apply those combo pads, anticipate an advanced airway. And we'll have to work on that spelling there. And of course, synchronized cardioversion, and of course, 12 lead post-cardioversion, so we can see where we're at. If we are stable, this is the fun part. So if we're stable and irregular is our branch point here. So let's start at stable and regular. And so if we're stable and regular, first thing we're going to do is we're going to perform those vagal maneuvers and see if we get any benefit. Obviously, if you know somebody has a huge history of carotid endarterectomy, has a big scar on their neck, you may want to avoid those vagal maneuvers before we cause any bad damage. Now, the same token, the next step then is we're going into giving adenosine. And this is going to be our 6, 12, and 12 like we've done in the past, and see if we get some benefit. If there's no response at that time, there's no reason to continue. At that point, consider just rate controlling, and you can use diltiazem for that rate control, and you can see the normal doses that we're used to using here. Nothing major difference here. This is kind of standard protocol that we've been doing for ages. On the flip side, if we look on the other side where we're talking about our patient who is irregular, when we start thinking about the irregular patient with narrow complex, I think we all kind of see the picture of an AFibber, right? And so we're going to treat them for aspirin because a lot of times AFib with chest pain or things like that can very well be an early presentation of ACS. And from there, we're going to go right to diltiazem. We're going to go to our cardizem, try to slow them down, get some benefit from that situation. And of course, do that 12 lead if there's any type of administration or conversion, so we can continue following the patient status. So that, my friends, is the tachycardia with narrow complex. We're going to progress from here to tachycardia with wide complex. Again, we focus again on our patient care objective for this one, and we have adequate oxygenation, ventilation, and perfusion. We're going to restore and hope to restore our regular sinus rhythm and think about those underlying causes again. Again, we're focusing at the beginning of this on adult universal care, going through our airway management. Click that hyperlink if you need more information. Of course, get that 12 lead EKG, see what we're dealing with, and place that IV so we have something to work with. Here, a fluid bolus is very appropriate. And we're back to our favorite box here. Is it stable or is it unstable? I swear it's like a game show, stable or unstable. And so we're going to go straight to the unstable and just reconfirm where we were before. That if they're unstable, consider that synchronized cardioversion, move rapidly to this point. After your cardioversion, get that 12 lead EKG. This is stuff that I think we're all very familiar with. On the flip side, let's talk about our stable group. And we talked about this at our last core comps, where we talked about 3 different groups: regular monomorphic, irregular monomorphic, and polymorphic. I'm going to start on the far left with our regular monomorphic. So these are our VTs, right? So the great part is ventricular tachycardia can safely be cardioverted with adenosine. Now, how often does that happen? Not very often, but it actually does work. And so you have the opportunity to do this, and you don't have to go through the full six. I have you down here for 6 and 12. Give it a chance, see if it works. If it doesn't, and if it's ineffective, move on to lidocaine down below. Again, we're sticking with lidocaine for ours. And then if there's a rhythm change, do that 12 lead EKG. These stable ventricular tachycardias need to get transferred as soon as possible. ACS is on the table, so we have to think about that too. With our irregular monomorphic, this becomes a little more confusing because these individuals with irregular wide complex monomorphic, they could be AFib with aberrancy, they could be our WPWs who are going fast. Those are the options that we have to think about. Amiodarone and lidocaine are the 2 medications. We have lidocaine in our rigs. If there's a change of course, do your 12 lead EKG to see where you're at. If they decompensate, what are you going to do? You're going to shock them, right? There's no questions here. Shocking is safe for these patients. Last one is our polymorphic VT. Now, this is our classic torsades patient. Make sure you give them magnesium. One of the challenges with these torsades patients is that oftentimes this is one of those rhythms that is going to decompensate on you. Expect the decompensation. So if you don't see a good conversion, prepare yourself in the unstable pathway because they're going to head in that direction. So now we've covered chest pain, bradycardia, chest pain, syncope, bradycardia, and tachycardias. So that would be the arrhythmias that are associated with our near syncopal episodes, or possibly even our chest pains. Where I want to take you now, is, now that we've done all that, is the worst case scenario. Say they go into cardiac arrest. In the process of trying to do the good things, sometimes this can happen. We did look at this previously. I just want to touch base on a couple of things. Obviously, we want to think about the criteria for withholding resuscitation and think about that, and that's right at the top. And then start CPR if we have no criteria for that. And of course, as we're starting CPR, think about what our resuscitation goals are. And these are things that we've practiced and know well from all of our simulation work and things like that. Again, keep hammering this in for yourselves. As we go forward, place that cardiac monitor and think of the fundamental question: shockable or not shockable? And this is such a huge question because it also determines a lot on resuscitation and survival, and also on on termination of resuscitation. So the shockable, unshockable is very, very important, that key. When we think about our non-shockable rhythms, we're thinking of PEA and asystole, right? And so you're going to continue CPR, IVIO, and early epinephrine is the goal here. There is clear improvement in outcomes for patients in the pre-hospital setting with early epinephrine if they have a non-shockable rhythm. And this is the only thing that's been proven to work. And so continue with that. Consider your airway management, and think about reversing those irreversible causes and cycle through your normal ACLS algorithms. At the bottom here, you're going to see a note here to consider ROSC and to also consider termination of resuscitation efforts. I think both of those things are important considerations. Now, on the other side, where we go to our shockable rhythm, as you would expect, if we have a shockable rhythm, I want you to shock them. Yes, let's get in there and let's shock the patient. Let's defibrillate them and bring them back to a normal rhythm. Of course, IVIO, go restart that CPR as soon as possible after you defibrillate. Try not to pause, try to pre-charge for our shocks. And of course, go get early epinephrine on board. Of course, again, consistent airway management. And now you have other treatments that you can consider, things like antiarrhythmics. Keep in mind, for us, lidocaine's on the list. And the great part about lidocaine, superior to amiodarone, is that it has the potential to decrease the risk of rearrest after somebody has been resuscitated. Of course, for torsades, think about MAG. For our dialysis patients, you have calcium gluconate. And for anyone with a tricyclic overdose, you have sodium bicarb. So that's our cardiac arrest patients. Now, our hope is that we get to the point that we have ROSC. So let's talk about our new ROSC protocol. Now, this is more an updated ROSC protocol because we had one in the past, I believe. So here we are. If there is return of spontaneous circulation, what do? Well, we perform a general patient assessment. Now you're going to support all the life-threatening conditions like airway, breathing, circulation, and really work through the whole list. We want to administer oxygen to get an appropriate target. We do not want to hyperoxygenate these patients. Do not also hyperventilate them. Think about 6 to 8 per minute, but we have our end-tidal CO2. And we're going to hook up our end-tidal CO2 during the cardiac arrest and resuscitation. So it should be here for us to be able to follow. From there, we're going to manage some of the harder things that we have to deal with. So first of all, manage the hypotension. A couple different ways: give some normal saline, fill that tank. At the same token, as that tank is being filled, consider now using a pressor. In this case, our push dose pressors. Get that 12 lead. Let's define if this is a STEMI or not, because it's going to tell us where we want to go. We need to know if that has a STEMI or not. And from there, post-arrest patients with evidence or interpretation consistent with a STEMI should be transported to any hospital. And with that being said, if you have somebody who is VT-VF arrest and now is ROSC, you can almost consider them a STEMI till proven otherwise, right? And so get them to a PCI capable facility, and then do all the your other due diligence. Check your glucoses and prepare for seizures. That these patients do indeed seize. So prepare for those scenarios. So now we've taken you through the gambit of the cardiac protocols, and we've kind of gone through all these protocols. Where did we start? We started at the point of talking about chest pain, and then we moved on to our syncope patients. And then we talked about all the arrhythmias that can challenge you with near syncope or chest pain patients, both bradycardia and tachycardia. We talked about our cardiac arrest patients and what do we do with those, which we've practiced serially a number of times. And last but not least, if they obtain ROSC, we have our plan for ROSC. So all those are all the different things. You can see that the protocol really isn't all that different, but it's nice to be able to go through it with you guys. So thank you again. Really appreciate your time. And we will go from there, and expect another video coming out soon to touch base on other parts of the protocol. Thanks, guys.